PMHNP Module 4 Video 4. Hi, my name is Tina Joel. This video is part of the Child and Adolescent series. In this video, we'll walk through how to accurately diagnose ADHD using structured tools. Please watch till the end of the video so you are aware of whether or not psychometric testing is needed for you to diagnose someone with ADHD and what the clinical diagnosis requirements are necessary. I've updated this video to clarify that psychometric testing is not required for you to give diagnosis of ADHD and how DIVA can be used for a detailed patient interview. I use DIVA tool in my practice along with other screening tools. I have now spent a few days just in making this one video due to the sheer details that are needed. As you delve into this video further, you'll realize and appreciate that no one probably has explained this topic to you in this much detail that really helps clarify a lot of questions related to ADHD diagnostic and screening tools. As we begin, it's important to remember that ADHD is not confined to childhood. It's a lifespan disorder that often continues into adolescence and adulthood. Symptoms may evolve over time from hyperactivity and impulsivity in younger years to disorganization and executive dysfunction in adults. This developmental continuity is why accurate early diagnosis, monitoring, and safe prescribing are so critical. Let's start by reviewing the key objectives that will guide today's session. Here are the objectives of this video. By the end of this video, you'll be able to strengthen your understanding of how ADHD is assessed and diagnosed using a structured, evidence-based approach. First, you'll be able to explain the diagnostic structure, specifically how DSM-5 criteria define ADHD across age groups and how symptom presentation may differ between children, adolescents, and adults. You'll also be able to discuss the clinical utility of standardized assessment tools, including the ADHD RS5, Vanderbilt, Conners, SNAP-4, ASRS, and CAARS, understanding what each measures, when to use them, and how to interpret results across informants. You'll also be able to understand the role of structured diagnostic interviews like the DIVA, and when formal psychometric testing may be indicated, for example, in complex presentations, differential diagnoses, or when learning disorders are suspected. Next, you'll be able to integrate these tools strategically into your workflow, recognizing that while they are essential for gathering objective data, they support, but do not replace, clinical judgment. And finally, you'll be able to recognize common differential diagnoses that can mimic ADHD symptoms, ensuring accuracy, reducing overdiagnosis, and improving patient outcomes. Now that you know what we'll be covering, let's begin by reviewing the foundations of ADHD diagnosis, understanding its neurodevelopmental basis, and why structured assessment is essential for diagnostic accuracy. Attention deficit hyperactivity disorder represents one of the most common neurodevelopmental conditions affecting children, adolescents, and adults worldwide. However, accurate diagnosis requires far more than casual observation or a single office visit impression. Structured assessment is the cornerstone of quality ADHD care because it distinguishes true ADHD from behavioral issues, ensures multi-setting symptom verification, and reduces both overdiagnosis and underdiagnosis. Without systematic evaluation, clinicians risk misattributing symptoms to ADHD when other conditions like anxiety, trauma, or sleep disorders may be the true culprit. The stakes are high. Proper early diagnosis leads to improved academic performance, better social relationships, reduced risk-taking behaviors, and enhanced long-term outcomes across the lifespan. When it comes to diagnosing ADHD, the foundation is built on understanding that this is a neurodevelopmental disorder, not a behavioral problem. ADHD is rooted in genetic, neurobiological, and neurochemical factors, not caused by poor parenting, laziness, or lack of motivation. Recognizing this distinction is crucial for reducing stigma, guiding compassionate communication with families, and ensuring treatment targets brain-based regulation rather than behavioral control alone. Accurate diagnosis also depends on a multi-setting, multi-informant approach. The DSM-5 criteria require that symptoms occur in at least 2 or more environments, such as home, school, or work, and that they cause functional impairment. This means you can't rely on a single report or setting. Gathering information from parents, teachers, partners, and self-reports paints a comprehensive and objective picture beyond what you see in the clinic. Another key principle is that early diagnosis yields better long-term outcomes. Children diagnosed and treated early show higher academic achievement, fewer high-risk behaviors in adolescence, improved emotional regulation, and better adult outcomes. Timely intervention prevents the cascade of secondary problems like school failure, low self-esteem, or substance misuse that often accompany untreated ADHD. Finally, we must always remember that misdiagnosis risk rises when screening is inconsistent or subjective. Without structured assessments, ADHD can easily be confused with anxiety, trauma, or learning disorders, or clinicians may overlook sleep problems mimicking hyperactivity. Using validated tools standardizes assessment, reduces bias, and enhances diagnostic precision. In short, high-quality ADHD diagnosis blends biological understanding, multi-informant data, early intervention, and structured evaluation. This is the cornerstone of safe and effective treatment. The Diagnostic and Statistical Manual of Mental Disorders, 5th edition, or DSM-5, provides the foundation for diagnosing ADHD. It ensures diagnostic consistency, but interpretation always requires a developmental and clinical lens. Using the DSM-5 criteria alongside structured scales allows clinicians to balance objectivity with context. Let's look closely at how DSM-5 defines ADHD and what core features establish diagnostic validity. And according to the DSM-5, ADHD is defined by persistent patterns of inattention and/or hyperactivity, impulsivity that interfere with functioning or development. These symptoms are divided into 2 main domains: inattention and hyperactivity, impulsivity, with 9 symptoms in each category. For a child or adolescent under the age of 17, at least 6 symptoms from one or both domains must be present. For adults, 5 or more are required. Symptoms should persist for at least 6 months and be inconsistent with the child's developmental level. Critically, they must occur in at least 2 or more settings, such as home, school, or social environments, to rule out situational factors. Onset must occur before age 12, emphasizing ADHD's developmental roots. Finally, there must be clear evidence that these symptoms cause significant impairment in academic, social, or occupational functioning. This distinction between symptoms and impairment is key. Many children are active or inattentive, but not all experience dysfunction. Understanding these criteria provides the foundation for diagnosis. Now let's review how ADHD can present across different symptom patterns. The DSM-5 identifies 3 main presentations of ADHD: predominantly inattentive, predominantly hyperactive impulsive, and combined type. The inattentive presentation often appears as daydreaming, forgetfulness, or difficulty sustaining focus. These individuals may seem internally distracted rather than overtly disruptive, which makes this form frequently underdiagnosed, particularly in girls. The hyperactive, impulsive presentation, on the other hand, is typically more visible, characterized by restlessness, fidgeting, interrupting others, and acting without considering consequences. This group often attracts early attention in school due to behavioral disruption. The combined type involves significant symptoms from both domains and tends to have the highest functional impact. Importantly, ADHD presentations are not static. They can shift across development. For example, a young child with hyperactivity may evolve into an adolescent or adult with primarily inattentive symptoms as impulsive behaviors settle, but executive deficits persist. Clinicians should also specify current severity, mild, moderate, or severe, based on the number of symptoms and degree of impairment. Recognizing these evolving presentations helps tailor both diagnosis and treatment to the individual's developmental stage. Structured rating scales transform subjective impressions into measurable data and provide a way to track progress over time. These tools bridge the gap between what families and teachers observe and what clinicians interpret, creating a shared language for symptom assessment. Using standardized scales alongside DSM-5 criteria not only improves diagnostic accuracy, but also helps document treatment response. Let's begin by exploring the pediatric rating scales most frequently used in clinical and educational settings, starting with the ADHD RS5. Now that we've covered the foundational principles of accurate ADHD diagnosis, let's turn our focus to the structured tools that make these assessments objective and reliable. In this next section, we'll explore the core ADHD rating scales used for children and adolescents and how each contributes unique insight into symptom patterns across home and school settings. The ADHD RS5, or ADHD Rating Scale 5, is considered the gold standard among ADHD rating tools because it aligns directly with DSM-5 diagnostic criteria. It's especially useful when a high degree of diagnostic precision is needed, such as in clinical research, psychiatric evaluations requiring DSM-5 fidelity, or cases where a provider is differentiating ADHD from overlapping disorders. This tool is widely used in both pediatric psychiatry and pharmacologic research because it translates DSM criteria into measurable items that guide treatment decisions and track outcomes precisely. Let's take a closer look at how the ADHD RS5 is structured, scored, and interpreted. There's the ADHD Rating Scale 5, also known as the ADHD RS5, is one of the most clinically validated and widely adopted tools for assessing ADHD severity and treatment response. It includes 18 items, 9 assessing inattention and 9 assessing hyperactivity, impulsivity, mirroring the DSM-5 diagnostic criteria for ADHD. Each item is rated on a 4-point Likert scale, 0 for never or rarely, 1 for sometimes, 2 for often, and 3 for very often. The total score ranges from 0 to 54 and can be broken down into 2 subscale scores: inattention, 0-27, and hyperactivity, impulsivity, 0 to 27. The parent version is typically used for children ages 5 to 17, while the teacher version provides essential corroboration of school-based behavior. The ADHD RS5 not only identifies symptom burden, but also helps quantify functional impairment, making it invaluable for monitoring medication response and guiding dosage adjustments. Higher scores reflect more severe symptomatology. For example, a total score above 36 generally indicates moderate to severe ADHD symptom presence, though interpretation should always be contextualized with developmental norms and collateral data. Clinicians should also note that the scale includes both a symptom frequency and performance impairment section, which helps determine whether reported behaviors are clinically significant rather than situational. It's an excellent instrument for baseline and follow-up assessments, as score reductions of 30% or more typically indicate a meaningful clinical response to treatment. Among the most widely used and practical tools in pediatric ADHD assessment is the Vanderbilt ADHD Diagnostic Rating Scale. Unlike the ADHD-RS5, which focuses strictly on DSM-5 ADHD criteria, the Vanderbilt provides a broader clinical snapshot, capturing ADHD symptoms alongside comorbidities such as oppositional defiant disorder, conduct disorder, anxiety, and depression. You'd typically use the Vanderbilt when evaluating school-age children in primary care, pediatric, or school-based settings where a comprehensive view of academic performance, social behavior, and emotional regulation is essential. It's also ideal when multiple informants, like teachers and parents, need to contribute structured feedback on a child's daily functioning. In the next section, we'll walk through the structure, scoring, and clinical application of the Vanderbilt, highlighting why it remains the most accessible and versatile screening tool for child and adolescent ADHD. Now, let's take a closer look at one of the most widely used ADHD screening tools in both primary care and psychiatric settings, the Vanderbilt ADHD Diagnostic Rating Scale. This instrument provides comprehensive symptom coverage, including the 18 core DSM-5 ADHD criteria, plus additional items that assess oppositional defiant disorder, conduct disorder, anxiety, and depressive symptoms. This expanded scope helps clinicians screen for common comorbidities in a single, efficient tool. The Vanderbilt also features dual informant versions, one completed by parents and another by teachers, allowing us to capture behaviors across both home and school environments. Each version uses a 4-point frequency scale from 0 to 3, mirroring the ADHD-RS5 structure to maintain consistency in interpretation. Another key feature is its performance impairment ratings. Unlike tools that focus only on symptom counts, the Vanderbilt assesses functional impairment across multiple domains: academic performance, classroom behavior, peer relationships, and organizational skills, using a 5-point scale ranging from excellent to problematic. Finally, the Vanderbilt aligns directly with DSM-5 diagnostic criteria. For an ADHD diagnosis, impairment must be present in 2 or more settings, typically home and school. Because of its comprehensive coverage and structured scoring, the Vanderbilt is an excellent tool for initial screening and ongoing monitoring in both primary care offices and school-based mental health settings. Next, we'll turn to the Conners rating scales, known for their precision and sensitivity in capturing ADHD symptoms and related behavioral or emotional patterns. While the Vanderbilt provides a broad overview suited for primary care and screening, the Conners is the tool of choice when you need diagnostic refinement and detailed functional assessment, especially in complex cases involving comorbidities like anxiety, mood disorders, or learning problems. This scale offers separate forms for parents, teachers, and self-report, providing a multi-dimensional view that helps clinicians move beyond surface-level symptoms. The Conners is particularly valuable in specialty psychiatry, neuropsychological evaluations, or cases where initial screening results are inconclusive. It allows for a more granular understanding of attention, executive functioning, and emotional regulation, essential for tailoring treatment and educational interventions. In the next section, we'll review the structure, scoring, and interpretation of the Conners rating scales and discuss how their validity indices enhance confidence in clinical decision-making. The Conners Rating Scales, now in their 4th edition, are among the most comprehensive tools for evaluating ADHD and related concerns in children and adolescents. The Conners 4, released in 2020, includes parent, teacher, and self-report forms for ages 6 through 18. This multi-informant design gives a 360-degree view of how the child functions across settings, home, school, and social environments, making it one of the most clinically useful rating systems available. Unlike simpler screeners that only measure ADHD symptoms, the Conners 4 also assesses executive functioning, learning difficulties, emotional distress such as anxiety and depression, and peer relationships. This allows clinicians to differentiate pure ADHD from broader cognitive or emotional problems that may influence attention or behavior. In terms of scoring, each item is rated on a 4-point frequency scale from 0, not true at all, to 3, very much true. These raw scores are converted to T-scores, standardized with a mean of 50 and a standard deviation of 10, so clinicians can interpret them relative to same age and same gender peers. A T-score of 70 or higher, which corresponds to the 98th percentile, indicates a clinically significant elevation, while scores between 65 and 69 fall into the high average range and warrant further consideration. Importantly, the Conners 4 also includes validity indices, such as inconsistency, positive impression, and negative impression scales, to detect random responding, exaggeration, or underreporting. These indices enhance confidence in the results and make the Conners 4 especially reliable for both diagnostic and treatment monitoring use. The Conners scales offer detailed multidimensional data, but in busy clinical settings, there are times when we need a faster, more streamlined tool for screening or progress monitoring. That's where the Snap 4 stands out. It's concise, freely available, and designed for efficient ADHD screening as well as tracking oppositional or defiant behaviors. You'd choose the Snap 4 when you need a quick baseline assessment, especially in primary care, pediatric, or school-based settings, or when resources are limited but structured data are still important. It's also ideal for treatment follow-up, where a brief and repeatable tool can track symptom changes over time without burdening families or teachers. In the next section, we'll look at the Snap 4's structure, scoring, and clinical use, and why it remains one of the most practical and widely adopted ADHD rating scales in day-to-day practice. The Snap 4 rating scale is one of the most practical and versatile tools for assessing ADHD symptoms and related behaviors in children and adolescents. It includes 26 total items divided into 9 inattentive symptoms, 9 hyperactive impulsive symptoms, and 8 oppositional defiant disorder items. This combination allows clinicians to screen not only for ADHD, but also for commonly overlapping behavioral challenges such as oppositionality and emotional dysregulation. Each item is rated on a 4-point frequency scale from 0 to 3, ranging from not at all to very much. Parents and teachers rate behaviors based on how often they occur over the past week or month, depending on the version used. This simplicity makes it ideal for busy outpatient and school-based settings. Scoring involves summing the item scores within each subscale, inattentive and hyperactive impulsive, and dividing by the number of items answered. A mean score greater than 1.78 on either subscale is generally considered clinically significant based on normative data. This cutoff helps clinicians determine whether symptom frequency and severity exceed developmental expectations. Clinically, the Snap 4 is a go-to tool for both baseline assessment and monitoring treatment response. It takes only 5 to 10 minutes to complete, can be used by multiple informants, and is completely free to administer. These advantages make it particularly valuable in primary care and school environments where access to paid rating systems may be limited. It's an excellent first-line tool to quantify ADHD symptom burden and track progress over time. Assessing ADHD in adults requires a different lens. By adulthood, symptoms often manifest as internalized experiences. Chronic disorganization, impulsive decision-making, poor time management, or restlessness that's less physical and more cognitive. To capture these lifelong patterns, several adult-specific rating scales have been developed that help clinicians quantify symptom severity, functional impairment, and persistence from childhood. These tools also aid in ruling out mimics like anxiety, depression, or sleep deprivation, which frequently overlap with adult ADHD presentations. The most widely used instruments are the Adult ADHD Self-Report Scale, known as the ASRS, and the Conners Adult ADHD Rating Scale, also called CAARS. Each provides structured, normed scoring that aligns with DSM-5 criteria and offers both screening and monitoring functionality. Using these validated tools helps standardize diagnosis and supports clinical justification for stimulant prescribing in adults, an essential step for both accuracy and regulatory compliance. The Adult ADHD Self-Report Scale, or ASRS, is the most widely used screening tool for ADHD in adults. It was developed jointly by the World Health Organization and Harvard Medical School and is available in two formats: the ASRS V111, which contains 18 items, and the ASRS Screener, which includes the first 6 of those items. The tool aligns directly with the 18 DSM-5 ADHD symptoms, 9 inattentive and 9 hyperactive impulsive, and is designed for individuals aged 18 and older. Each item is rated on a 5-point frequency scale from 0, never, to 4, very often, and focuses on the past 6 months of functioning in work, relationships, and daily life. The 6-item screener is especially practical for busy clinical settings because it has been validated to detect roughly 90% of adults with ADHD. For scoring, if 4 or more of the 6 screening items are marked as often or very often, further evaluation is indicated. The full 18-item version allows for more granular analysis across inattentive and hyperactive domains and can be repeated to track symptom changes over time. The ASRS also provides a way to open discussions about ADHD without stigma. Patients often find its wording relatable and descriptive of their daily struggles, which fosters openness and insight during the diagnostic interview. In clinical practice, this scale is an excellent entry point for adult assessment, particularly when combined with developmental history and corroboration from family members or school records that indicate symptom persistence from childhood. The Conners Adult ADHD Rating Scale, or CAARS, takes ADHD assessment in adults a step further by offering a multidimensional view of symptom severity, executive functioning, and emotional regulation. Unlike quick screeners like the ASRS, the CAARS is a comprehensive, normed instrument that allows clinicians to compare an individual's scores to population averages. It's especially useful for confirming diagnoses in complex cases, such as adults with overlapping anxiety, depression, or trauma histories, and for documenting impairment when initiating or renewing stimulant treatment. The CARS provides both self-report and observer forms, helping capture discrepancies between self-perception and external observation, which is crucial for diagnostic accuracy. The Conners Adult ADHD Rating Scale is a gold standard, norm-referenced tool for adult ADHD assessment that provides both self-report and observer-rated versions. It's suitable for adults aged 18 and older and is available in multiple forms: a full-length version with 66 items, a short 26-item screener, and a 30-item self-report designed for follow-up assessments. Each item is scored on a 4-point scale from 0, not at all, never, to 3, very much, very frequently. The CARS measures core ADHD symptoms across 4 primary domains: inattention, memory problems, hyperactivity, restlessness, impulsivity, emotional lability, and problems with self-concept. Additional indices assess executive functioning, mood instability, and social functioning, which can reveal comorbid issues not captured by other scales. The results are converted into T-scores based on gender and age-adjusted norms, with a T-score of 65 or higher generally considered clinically significant. The CARS also provides an inconsistency index to detect random or contradictory responses. Useful for assessing response validity, especially in medico-legal or high-stakes prescribing contexts. Clinicians often use CARS at baseline to establish diagnostic clarity and repeat it periodically to monitor response to stimulant or non-stimulant treatment, particularly in workplace or academic functioning. Its detailed scoring output allows for targeted treatment planning, helping to determine whether persistent symptoms stem from ADHD itself or from overlapping mood, anxiety, or sleep issues. I know you have heard a lot of confusing things whether psychometric testing is required for ADHD diagnosis or not. Please allow me to clarify in the next few slides. Psychometric testing refers to standardized assessments designed to evaluate cognitive, attentional, and behavioral functioning in a structured way. These tests measure specific cognitive domains such as working memory, processing speed, executive function, and attention regulation. Examples include the Continuous Performance Test, or CPT, Stroop Task, and Test of Variables of Attention, or TOVA. While these tools can provide objective data about attention and impulse control, they are not diagnostic on their own. Psychometric testing is most useful in complex or ambiguous cases, particularly when symptoms overlap with other conditions like learning disorders, traumatic brain injury, or mood disorders. These tests are typically administered by neuropsychologists and interpreted in conjunction with clinical history and observational data. For PMHNPs, psychometric testing is considered supplemental, not essential to establishing a diagnosis. The clinical interview and DSM-5 criteria remain the foundation for ADHD diagnosis, but psychometric results can support or clarify the diagnostic picture, especially in multidisciplinary or academic settings. Now that we understand what psychometric testing contributes, let's clarify how a PMHNP determines an ADHD diagnosis and where the distinction lies between comprehensive testing and clinical diagnosis. Psychometric testing can enhance our understanding of a patient's cognitive profile, but the ADHD diagnosis itself is ultimately a clinical one, rooted in history, observation, and functional impairment. Unlike neuropsychological testing, which measures performance on standardized tasks, the PMHNP's role is to synthesize data from interviews, behavior reports, and rating scales to determine whether the DSM-5 criteria are met. In this next section, we'll walk through the core requirements for a PMHNP to make a valid clinical diagnosis of ADHD and when, if ever, additional testing is warranted. To make a clinical diagnosis of ADHD, PMHNPs must base their assessment on the DSM-5 TR diagnostic criteria, which require that symptoms of inattention and/or hyperactivity impulsivity be present in at least 2 or more settings, such as home, school, or work, and cause significant functional impairment. A thorough clinical interview remains the cornerstone of diagnosis, focusing on developmental history, family history, psychosocial factors, academic or occupational functioning, and symptom onset before age 12. The PMHNP should also obtain collateral information from parents, teachers, or partners, as children and adults may under or overestimate their difficulties. Importantly, a PMHNP does not need formal psychometric testing to diagnose ADHD. The diagnosis is clinical and supported by structured rating scales and corroborating evidence rather than performance-based cognitive testing. Screening tools like the Vanderbilt, Conners, or ASRS provide structured data points that guide but never replace clinical judgment. The provider's role is to synthesize all available information to determine whether symptoms meet threshold criteria and are not better explained by another condition or environmental factor. Now that we've reviewed how PMHNPs establish a clinical diagnosis, let's look at the purpose and proper use of screening tools, how they fit into assessment, and what they can and can't tell us. Screening tools are not meant to diagnose ADHD, but rather to structure and standardize the assessment process. They help quantify symptoms, identify areas of concern, and ensure consistency across informants like parents, teachers, and patients. For example, rating scales can confirm whether symptoms occur in multiple settings and track response to treatment over time. In this next section, we'll take a closer look at how these tools, including the ADHD RS5, Vanderbilt, Conners, SNAP-4, and the DIVA, fit into diagnostic practice, when to use them, and what their results actually mean. When assessing ADHD, it's essential to understand the specific role and limitation of each tool we use. Screening and rating scales, such as the ADHD RS5, Vanderbilt, Conners, and SNAP-4, are structured instruments designed to help clinicians gather systematic information about symptoms across different environments and from multiple informants. These tools enhance objectivity, allow for comparison with normative data, and help track progress over time. However, they do not diagnose ADHD. They serve as data points that support clinical reasoning and confirm the presence of behaviors consistent with ADHD. The DIVA, or Diagnostic Interview for ADHD in Adults, stands apart from these tools. Unlike symptom checklists, the DIVA is a structured clinical interview, not a screening instrument. It is specifically designed to guide clinicians through a comprehensive diagnostic conversation that compares childhood and adult symptoms based on DSM criteria, ensuring a more precise and culturally sensitive evaluation. In the next slide, we'll take a closer look at what makes the DIVA so unique, how it's structured, and how it should be used appropriately in clinical practice. The DIVA, or Diagnostic Interview for ADHD in Adults, is a structured, semi-clinical interview tool specifically developed to ensure consistency and accuracy in diagnosing ADHD based on DSM-5 criteria. Unlike screening scales that provide symptom ratings, the DIVA guides the entire diagnostic conversation. It walks clinicians through each ADHD criterion with examples of how symptoms may present in both childhood and adulthood, ensuring that the assessment remains anchored in real-world functioning rather than vague recall. What makes the DIVA especially valuable is its cultural and contextual neutrality. The questions use practical, relatable examples such as missing deadlines, interrupting others, or difficulty maintaining organization at work or school. This helps patients recognize symptoms they may have normalized over time. The DIVA also helps differentiate ADHD from other psychiatric disorders by clarifying how often, how long, and how severely symptoms have impacted daily life. It's available as the DIVA-5, DSM-5 version, and the official tool can be accessed for licensed use through the DIVA Foundation website, which provides translations in multiple languages. While it can be used by trained PMHNPs, it's important to remember that it is not a test, but a structured diagnostic aid, a clinical roadmap that ensures every DSM-5 criterion is evaluated with specificity and consistency. The DIVA complements rather than replaces your clinical interview and collateral information. Now that we understand what the DIVA is and how it differs from screening scales, let's look at how it's applied in practice, specifically how each DSM-5 criterion is explored through real-world examples during the interview. DIVA Prompts just makes the diagnostic interview questions more relatable to patients, and that's all. You see, in that way, it is quite different than the screening tools. When using the DIVA in clinical practice, the goal is not to read questions verbatim, but to guide the patient through real-life scenarios that illustrate each DSM-5 ADHD criterion in both childhood and adulthood. The DIVA provides multiple examples per criterion to help the patient identify experiences that fit their developmental context. For instance, when assessing inattention, the tool might explore whether as a child the patient often forgot homework, lost items, or daydreamed in class, and as an adult, whether they struggle with deadlines, organization, or sustaining focus during meetings. Similarly, for hyperactivity impulsivity, childhood examples might include constant fidgeting, excessive talking, or difficulty waiting turns, while adult equivalents include restlessness, interrupting others, or difficulty engaging in quiet leisure activities. The DIVA's structured format encourages the provider to ask clarifying questions that translate abstract DSM criteria into concrete, functional behaviors. For example, instead of asking, "Do you have trouble paying attention?" you might ask, "Do you find yourself rereading the same paragraph multiple times because your mind drifts?" Or, "Do you miss appointments unless you set multiple reminders?" These examples help patients connect symptoms to lived experience rather than theoretical labels. Another key feature is that the DIVA separates each domain into frequency, severity, and impairment. The clinician documents whether symptoms occur in multiple settings, home, work, or relationships, and whether they cause significant distress or dysfunction. This ensures that a diagnosis of ADHD is based on both symptom presence and impact, not just endorsement of traits. Now that we've looked at how the DIVA is used to explore each DSM-5 criterion in detail, let's clarify a common misconception: whether tools like the DIVA, Vanderbilt, or Conners can actually be used to diagnose ADHD, or if their role is something different entirely. Here is some information about the DIVA tool. Where to get it: you can purchase the tool through the DIVA Foundation website shown on this slide. Also, here is some information on cost and licensing terms. The standard fee is €10 per clinician for unlimited downloads of the DIVA-5 PDF version. Once purchased, the clinician can download the PDF and use that version indefinitely. If you are purchasing for an organization with multiple users, you inform the foundation the number of users and pay accordingly. That is €10 for lifetime use for every clinician who is using the DIVA tool. Usage is based on an honesty system for clinics. Codes for downloads are per clinician. For how long can you use it? Once you download it via the purchased code, you may use that version indefinitely. There is no built-in expiration for the PDF version, i.e., lifetime use of that downloaded version for that clinician. It's important to clarify a point that often confuses both new clinicians and even some experienced providers. No screening tool, including the Vanderbilt, Conners, or SNAP-4, is sufficient on its own to diagnose ADHD. These instruments are designed to support clinical decision-making, not to replace it. They help the provider gather standardized, objective data about symptom patterns, frequency, and impact across multiple settings. For example, rating scales quantify parent or teacher observations, while structured interviews like the DIVA does ensure that every DSM-5 criterion is systematically explored. But ultimately, the diagnosis rests on clinical judgment, guided by evidence of impairment in 2 or more settings, onset during childhood, and exclusion of other causes such as trauma, mood disorders, or sleep deprivation. Psychometric and screening tools serve 3 main purposes. First, they provide structure, ensuring clinicians don't overlook key symptoms or functional impairments. Second, they enhance validity by including input from multiple observers. And third, they support longitudinal tracking, allowing providers to measure symptom changes over time and response to treatment. In short, these tools refine the accuracy and consistency of ADHD evaluation, but they do not determine the diagnosis. The PMHNP must synthesize data from history, collateral sources, mental status exam, and functional assessment to make a definitive clinical judgment. Now that we've clarified the distinction between supportive tools and clinical diagnosis, let's review how all of these components come together. Psychometric testing, structured interviews, collateral information, and clinical evaluation to form a comprehensive ADHD assessment process. I know some of this information may sound very repetitive, but it's necessary to consolidate, especially if you keep getting questioned again and again about psychometric requirements. You need to be able to say that it's not required and use your clinical judgment to use screening or diagnostic tools. When integrating tools like the DIVA, Vanderbilt, Conners, and SNAP-4 into the ADHD evaluation process, the key is to use them strategically as structured supports that complement, not substitute, your clinical expertise. The foundation of an ADHD diagnosis remains a comprehensive psychiatric evaluation that includes developmental history, symptom chronology, functional impairment assessment, and ruling out alternative explanations. Psychometric tools enhance this process by providing standardized data points from multiple perspectives. For example, a PMHNP may use the Vanderbilt for teacher and parent input, the Conners for detailed behavioral profiling, and the DIVA to guide an adult interview based on DSM-5 criteria. Together, these tools triangulate symptom patterns across informants and timeframes, increasing diagnostic confidence. It's equally important to remember that psychometric testing, such as formal neuropsychological assessments measuring working memory, processing speed, or executive functioning, is not required to make a clinical ADHD diagnosis. While these tests can be useful when diagnostic uncertainty remains, such as distinguishing ADHD from learning disorders or cognitive impairment, they are not part of routine diagnostic criteria. The PMHNP's role is to gather sufficient clinical and contextual evidence to establish that symptoms are pervasive, impairing, and developmentally consistent with ADHD. Screening and rating tools are used primarily for symptom quantification, treatment monitoring, and documentation, while diagnosis rests on the provider's synthesis of all available data. Now that we've covered how these tools fit within the larger diagnostic process, let's close by summarizing the core principles that guide evidence-based ADHD assessment and why maintaining a structured yet flexible approach is essential in clinical practice. Now that we've covered the major adult ADHD scales and tools, let's shift to how these tools come together in clinical practice, specifically how to integrate them into diagnostic workflow, documentation, and communication with patients and families. When using ADHD rating scales, how we implement them is just as important as which ones we choose. These best practices ensure diagnostic accuracy, treatment monitoring, and consistent communication across providers. First, always emphasize multi-setting data collection. To meet DSM-5 diagnostic standards, symptoms must be observed in at least 2 settings, typically home and school for children, or work and home for adults. For pediatric cases, this means obtaining both parent and teacher forms. For adults, collateral input from partners or supervisors can be incredibly valuable. Second, use rating scales for pre- and post-treatment tracking. Administer the same tool at baseline and at regular intervals, usually every 4 to 6 weeks during titration, to track medication response and functional improvement. This provides quantitative data that guide dosing decisions and objectively demonstrate treatment efficacy beyond subjective impressions. Third, ensure thorough documentation in the medical record. Always record the specific tool name and version, informant source, raw or standardized scores, and your interpretation. This documentation is essential for continuity of care, especially when patients transition between providers or need disability or educational documentation. Finally, prioritize results discussion with patients and families. Don't just report scores, translate them into meaningful feedback. Highlight strengths and areas for growth, discuss functional implications, and involve the patient or family in shared goal setting. This collaborative approach enhances engagement, adherence, and overall treatment success. One of the most important parts of ADHD assessment is knowing when the symptoms might not actually be ADHD. Inattention, impulsivity, and hyperactivity can stem from many other causes, such as trauma, sleep deprivation, depression, anxiety, or learning disorders. A thorough differential diagnosis ensures we don't miss underlying or coexisting conditions that could change treatment decisions entirely. Ruling out these mimics is as critical as confirming ADHD itself, because stimulants can worsen symptoms when the root cause lies elsewhere. Let's explore the most common conditions that overlap with or mimic ADHD and how to distinguish them clinically. When evaluating ADHD, one of the most important clinical skills is recognizing what isn't ADHD. Many medical, neurological, and psychiatric conditions can mimic or even coexist with attention deficits, leading to frequent misdiagnosis if not carefully ruled out. Under medical and neurological conditions, sleep disorders, particularly obstructive sleep apnea or chronic sleep deprivation, often cause inattention, irritability, and hyperactivity that resemble ADHD. Thyroid dysfunction, especially hyperthyroidism, may present with restlessness or cognitive slowing. Seizure disorders, such as absence seizures, can appear as frequent spacing out episodes mistaken for inattention. Sensory deficits, including uncorrected vision or hearing problems, can make a child miss instructions or appear distractible. And finally, medication side effects from antihistamines, benzodiazepines, or anti-epileptics can reduce alertness and focus, falsely suggesting ADHD. On the psychiatric and developmental side, anxiety disorders can impair concentration due to excessive worry and rumination, while major depression can cause slowed thinking or restlessness, mimicking inattention or hyperactivity. Trauma and PTSD frequently present with hypervigilance, dissociation, and mood swings that overlap with ADHD symptoms. Autism spectrum disorder involves attention shifting and difficulty with transitions, and specific learning disorders such as dyslexia or dyscalculia can cause academic underperformance that's mistakenly attributed to distractibility. A key clinical reminder: true ADHD is chronic, pervasive, and persistent. It begins before age 12, occurs across multiple settings, and is not episodic or situation specific. Always anchor your differential diagnosis to these three features to avoid over or underdiagnosis. By this point, we've covered the full foundation of ADHD assessment, from recognizing core symptoms to selecting the safest and most effective medication. The next step is bringing all of it together into a seamless, structured workflow that ensures accuracy, safety, and consistency in clinical practice. Integrating these steps allows prescribers to make informed decisions, improve patient trust, and streamline documentation. As we end this video, let's review the key takeaways that form the foundation of accurate ADHD assessment. First, remember that ADHD is a neurodevelopmental disorder, not a behavioral problem. It arises from genetic, neurobiological, and neurochemical factors, not from poor parenting or lack of discipline. Recognizing this distinction helps reduce stigma and ensures that care is rooted in compassion and evidence-based practice. Second, structured assessment tools are non-negotiable. Rating scales like the ADHD RS5, Vanderbilt, Conners, and SNAP-4 provide objective, norm-referenced data that improve diagnostic accuracy. They help clinicians balance the risk of over- and underdiagnosis by moving beyond subjective impressions. ADHD cannot be reliably diagnosed through casual observation alone. It requires systematic data from multiple informants and settings. Finally, always rule out mimics before confirming the diagnosis. Symptoms such as inattention or hyperactivity are not unique to ADHD. They can also occur in sleep disorders, anxiety, depression, trauma, or learning disabilities. A careful differential diagnosis prevents mislabeling and ensures that the right condition is treated. These principles, understanding ADHD as a brain-based disorder, using structured tools, and ruling out mimics, form the ethical and clinical foundation for all subsequent decision-making in ADHD care. Now that you've mastered the diagnostic framework and baseline prescribing principles for ADHD, we'll move into the next video of this series: non-stimulant and adjunctive medications. In the upcoming module, we'll explore evidence-based use of atomoxetine, bupropion, guanfacine, and clonidine, as well as the role of tricyclic antidepressants in ADHD management. You'll learn when to choose non-stimulants over stimulants, how to combine them effectively, and which patient populations may benefit most from these approaches. This next video will tie everything together, expanding your prescribing confidence beyond stimulant-based treatment. Thank you for joining me for this session. Not much time is spent in graduate education in explaining the different types of tools that are available to help you with diagnosing and screening a complex spectrum diagnosis such as ADHD. No matter where you are in your PMHNP journey, whether you're in training, preparing for boards, or starting in clinical practice, Cheducation resources are here to support you. You can access the PMHNP QBank Companion course, notes, and mastery modules in the Cheducation app to keep building your clinical confidence and prescribing expertise. I'll see you in the next video where we continue our ADHD Mastery series with a deep dive into methylphenidate-based medications.